Good afternoon, everybody. It's a big pleasure to be here. I'm going to introduce to you or further explain the use of some clinical laboratory procedures for early detection of cancer as well as follow-up by clinical laboratory procedures. These tests are extremely important because this will give a physician and an individual some leads as to is there really a cancer thing going on in the body or not. Already we have several hundred doctors on board from all the continents who are interested and who are using our tests. Some may be here at this point, and they see the importance of it. We've heard a lot about genetics and epigenetics. I have a degree in molecular genetics from Florida State, as you heard it before, so I'm quite good with genetics, but I'm really looking at the applicability of genetics, particularly in patient care like right now. What epigenetics tells me is that right at the point or at the moment of conception, we have a set of genes which are the combination of our parents, our mother and father. And some of these genes are good, some of them are not so good. Some of these genes can keep us healthy, and some of them can kill us. So we have cancer genes. And these cancer genes are dormant, very obviously, for a length of time. And what I didn't know for so many years since I'm into metabolic medicine, that what I was doing was actually, I was doing or working with the principles of epigenetics, which is telling me about good and bad genes, and that, as we already heard that, gene behavior can be changed. But you need to know whether there is a bad behavior or not before it expresses itself. And this is where the cancer profile will be very important, and together with that, the longevity profile. Well, we know that most individuals will develop cancer when they are in maybe the third period of their lives, the third 25 years of life. And the interesting thing is that they had the propensity to do this right at the moment of birth. But it doesn't happen. It didn't happen. So there's something that makes this very unfortunate situation to happen. And these are environmental conditions. And to me, this is simply what we eat, what we don't, what we drink, what we don't, what we do, what we don't, what we think, what we don't, all these things. So these genes are suppressed, and we are very well off. However, there are some genes which are immediately expressed at birth, like homocystinuria, for instance, or the hemoglobinopathy with most African population. There is. These are immediately expressed, so these genes are there and they are expressed, and if not found early enough, they can be life-threatening. So in the metabolic medicine, then, I'm realizing now the purpose or the point is to change gene behavior, put them back to dormancy. Yesterday I heard that our chromosomes are packed with bacterial genomes, and I know that with viral genomes. These live things incorporate into our own DNA, and they stay there dormant. And you can look at the herpes viruses, for instance. You don't get rid of them, but you can put them back to dormancy into the gene, and they just become quiescent and don't bother you any longer, as long as you can keep them at bay with your lifestyle. And you heard so much about this, the change or acquiring a new lifestyle which will not be very suitable for these genes to become active and not to make viral particles which can be killers. Again, as we are testing for the cancer profile and the longevity profile, we find very, very exciting, important, and sometimes alarming things. What one needs to remember and know that the cancer profile can be good and it can be bad. That means it can be negative and it can be positive. In so many individuals, as I will show you, the profile is positive when there is a person with absolutely no diagnosis. Everything is fine. The profile can, or some of the markers in specific, can indicate whether an individual is in a process of developing cancer, which may happen as many as 10 years down the road. We also know that cancer to develop takes 8 to 12 years or so. So there is a T0 when it starts, and then it goes on. And if someone is catching this development and arresting it in time, that's when cancer can be reversed. And this goes very well in line with the idea, the science of epigenetics. You're going to put these genes back to dormancy. You shut them off, and that would be the end of the story. Other than that, what I am realizing in my practice, so to speak, of 35 years is for cure for cancer, what I see is, with my own eyes and in my own office and laboratory, to me, the number one cure is the will of God. The number two cure would be a spontaneous remission, which is a miracle. The number three cure would be a successful early surgery. And the number four would be a successful metabolic therapy, which could put these genes back to shut up. Okay, and I have so many slides that I hope I can go somewhere here. The title was The Role of Human Autocrine Motility Factor in Tumor Malignancy. As I will show you, the tumor markers that I am using, one very important one is the HCG hormone, human chorionic gonadotropic hormone. We've been using 3 different tests for this. Unfortunately, we can only do 2 because the German source for this very special test dried up. We can't do that anymore, but the 2 are just as good. Okay, this hormone is the autocrine proliferating factor. That means that this hormone will have the propensity for initiating de novo DNA, RNA, protein synthesis, and the cells that producing it will multiply. And the way to detect the presence of this hormone, of course, is by very sensitive clinical laboratory procedures. The other most important marker is called PHI, phosphohexose isomerase. This is also called glucose phosphate isomerase, and it is the autocrine motility factor. There is so much literature on both the HCG hormone as well as the PHI enzyme that you can just turn green to go to half of it. I'm quoting somewhere there's more than 3,000 pieces of literature, just one or the other. The autocrine motility factor, this enzyme actually is a cytokine. I will go through the slides in a minute. This means that the enzyme is made in the cytoplasm of a cell at high concentrations. It will leave the cell and it will dock on the same cell surface. That's why it's autocrine, where there are docking sites already been created by genetic work. And when this docking occurs of this enzyme will take the name of a neurokine. This is a neurokine now, which causes the cells to vibrate, dislodge, and go somewhere else. So I am very convinced that this enzyme is the reason for circulating tumor cells and also metastasis. So as I see it, there is cancer spread can be promoted, initiated either by this enzyme or possibly an escaped cell from the surgeon's knife or from the biopsy needle. But this enzyme definitely plays an extremely important role in cytokinesis, cell movement. I need to do experiments, tests to actually prove that this is the circulating tumor cell, but this is the only way that the cell really will go from one place to another. It will dislodge from a tumor and go somewhere else. How do I go here? As you already know, Dr. Mayo said the aim of medicine is to prevent disease and prolong life. And that's what you all are involved with, and this is probably the main reason why you are here, to enhance patient life, longevity, and we hear so much about it. There are so many ways to do this. The facts are what we do, what we don't, what we eat, what we don't, what we think, what we don't, what we drink, all those things. And this is toxicity and or getting rid of such. Historically, there are tumor markers being in use for many, many years, some even more than 50 years, the HCG hormone, for instance, and there were a number of publications. Initially, there was John Baird, the English, the British researcher. He found the HCG in tumor cells, and he observed that this HCG was produced by certain embryonic cells called trophoblasts. These trophoblasts are corrosive and invasive, and it's very important for them to create the implantation site. I have tested stem cells in our laboratory, and I find, of course, that stem cells also produce HCG. And that's very natural because stem cells need to reproduce. So that's very important. There was a publication in the Journal National Cancer Institute where, again, Dr. Williams found HCG and used some other markers. And he found that these markers preceded the development of cancer by several years. I published a short paper in Clinical Chemistry in 1980 on this matter. And then I've been presenting on this a number of times in a number of places. I thought that before I go into the scientific detail, because of short of time as always is, I first will present some cases. This one is a 72-year-old woman who has no clinical diagnosis, but as you can see that she has some HCG in her blood and also in her urine. Her PHI enzyme is quite elevated. Don't forget, HCG is the autocrine proliferating factor. This one is the autocrine motility factor. So these both are contributing for the spread growth of cancer. Also has, her liver enzyme is fine. The carcinogenic antigen is quite elevated. DHA is that of a 100-plus-year-old person, so her immunity is suppressed because DHA is important for adrenal stimulation and contribution to T-cell production, thymic lymphocyte production. Her TSH indicates that she is also hypothyroid. So she has all these things that a physician would have never known unless does some kind of a profile similar to these things. Whatever her problem was, I think she came to us for prevention. This is another individual here. This is a 69-year-old person, female, has lymphadenopathy with nodules in the lungs. You see that she has quite a bit of HCG here. The normals are less than 1 MIU per ml. In the urine, we find that also, interestingly, the urine HCG is very rapidly broken down. But we usually collect first morning urine, so we'll have some kind of an estimate. Maybe someday we're going to collect 24-hour urine. But remember that this is MIU per ml. So if the person is voiding a liter, 1,000 milliliters of urine a day, that's going to be a hell of a lot of HCG there. Okay, the PHI enzyme is quite elevated. Liver enzyme is elevated. The carcinogenic antigen is normal. DHEA, that of a 90-year-old person, the TSH is on a high side, so she's hypothyroid. In a sense, she needs thyroid support. This one is a 72-year-old male, no diagnosis. This is a screening on this individual. I only enumerated the positives in these slides mostly. Has a lot of HCG in his urine. A 72-year-old male is not pregnant. You can be certain about that. And his PHI enzyme is very elevated. That means there is a very strong propensity for a malignancy because of the HCG and the PHI. And look at her CEA. The carcinogenic antigen was designed to monitor colorectal cancers, but it's not a very good marker for that. So if such a CEA occurs, I usually recommend to do the CA19-9, which is a better marker for pancreatic colorectal cancers. He has no progesterone as we're testing that. His testosterone is very low. C-reactive protein is very high according to our standards, like 10 times as high as it should be. The homocysteine that we did, the coronary risk factor, these are, as you know, he had the propensity for a heart attack or a stroke, 44.3% above average, and his lipoprotein small a was also high. So in this person, this is a screening procedure. Just imagine what all you can do. Oftentimes when we see an elderly male or female, we always ask if they are doing hormone replacement therapy. Now let's like to show you how important that would be. Of course, some people think there's some dangers to this as well. This is a 51-year-old Michael guy with stage 4 colon cancer. The PHI, phosphoexoisomerase, the autocrine motility factor, is very high on this person. There is a date 1 and there is a date 2 undergoing metabolic therapy, gene suppressing therapy, what it is. His liver enzyme is elevated. His carcinoembryonic antigen is good. His DHEA was very low, but once he started on a program, it went up to 400 something. So the adrenal anti-stress pro-immunity longevity hormone DHEA level is increasing. So according to this, his immune status is actually elevating. His testosterone was low, and now he's on a hormone replacement therapy, and it went up a little bit. I would like to see him with at least 700-800 of that. His C-reactive protein dropped about half of what it was. The inflammatory protein, we heard so much about the inflammation as being present in practically any, particularly chronic diseases. And his LDL direct was in a danger zone, very high, and it dropped down, but it's still very high. But this individual, as you can see it, it's improving altogether and in general as a result of attempts to silence the genes in the principle of epigenetics. This is this third famous PHI enzyme, which nobody practically know about. Phosphoexoisomerase, it is a dimer. I'm trying to, one day maybe I can test this and see maybe one of these dimers is responsible for cancer, because this is a very important enzyme in a red cell. It is providing the red cell with survival when it's traveling from where it gave off the oxygen while it gets back to the lungs and become aerobic again. Both the PHI enzyme and the HCG hormone are produced generally in anaerobic conditions. Here are some of the characteristics of this enzyme. This is, it regulates the Ebner-Meyerhoff glycolytic pathway. And like I say, it is anaerobic. It is a cytokine, a neurokine, cellular morphogenesis. All these are its characteristics. It's responsible for cytokinesis, cell migration, metastasis, angiogenesis promoter, ascites accumulation, all the many things. It's a metastatic factor. Pfizer is working on an inhibitor, and now we have found a natural herbal substance which been documented that it does inhibit PHI activity, and I think this is a fantastic discovery. It is also mitogen, causes cell division, as we know, that cell division. This one. That's just pretty much the same. It's a neurokine, a circulating tumor cell cause. It is responsible for micrometastasis. Lately, physicians are discovering that metastasis really doesn't just happen after a cancer is diagnosed, but it's already happening while it's really going on. The important thing is that both of these tumor markers can be detected as many as 10 years before there is a tumor. So the reason for this is because I am not looking for a tumor. A tumor has to be about 3 millimeters in size before the CT or the MRI or whatever can detect it. What I am looking for is the products of the tumor, and both HCG and PHI are those, and so would be the CEA when it shows up. CEA, carcinoma embryonic antigen, seem to be a relatively good breast marker. There's more about it. Interestingly, there was a report here where under hypoxic conditions, the AMF, which is a PHI enzyme, increased pancreatic cancer presence and activity. So there are several such studies. We know that it is actually a survival factor for cancer cells because they prefer anaerobic metabolism. Here are some of the maladies that this PHI enzyme was detected in, but whatever is not here, I'm sure is going to be in there. Very interesting finding. I found that the PHI enzyme will inhibit the therapeutic, so-called effect of Herceptin, trastuzumab. This is a very important finding, and I can bet that most oncologists are not aware of this, because this treatment modality could be rather expensive and it could be in vain, knowing that this enzyme is there. So first they need to suppress this enzyme production before this particular modality would be useful. Okay, these are some of the things again where PHI could be elevated other than cancer in an acute heart, liver, muscle disease, in a viral infection, carcinogenic viruses, of course, hypothyroidism, because a low thyroid will decrease basic metabolic rate and oxygen consumption by the individuals, and that availability to the cells. In developing cancer, existing cancer, and recently I found some literature that is also may well be elevated in psoriasis. Very interesting. But all these things can be very quickly ruled out when there is nothing of these and there is no diagnosis. Then that's a developing cancer, which may still take another 10 years. Now imagine if you knew this 10 years ahead or 8 or 5 years ahead. There is no tumor yet, but there are markers. That's the time when you could really effectively educate, punish these bad genes and put them back into dormancy. Much more likely when there is already a tumor and you start to hit them with chemo and radiation. If the surgery is successful, which I would know if the PHI is post-surgery normal, then that could be the end of the story, of the cancer story, because the tumor is removed. But of course, the lifestyle change is still necessary because an individual has the gene and has the propensity to have cancer. But at that moment, the tumor was taken out. So I try to educate my patients, okay, you had surgery, now you work on prevention. Forget about cancer. And of course, prevention is not an easy thing. It requires a lot of discipline and a lot of will. Okay, this one tells about the HCG as it's actually immune suppressant, and it is the autocrine growth factor. I call it the autocrine proliferating factor. It causes tumor cells to proliferate. Why would that 72-year-old man or a 60-year-old woman have HCG in their blood? This will be a very interesting thing that's coming up in a minute. HCG attributes, it is expressed by at least 48, or has an effect on at least 48 genes back when this was. Since then it's probably doubled that, but it's been documented that this hormone is extremely powerful. So those who are doing HCG diet have to be careful with that and definitely need to follow the patient's serum level of other tumor markers together with the HCG. We had several instances that ladies who were on HCG diet and they develop breast cancer. Whether there's a direct correlation or not, I don't know. It may be just a coincidence, but I saw it in 4 or 5 cases. Okay, see, there are some of the attributes of HCG, permanent disintegration of corpus luteum. This is a pregnancy thing. Male, female gonad enhancers. You know, men who use testosterone for bodybuilding and stuff, they use HCG to keep their testicles working, I guess. Increase de novo DNA, RNA protein synthesis, tumor marker. I'm mentioning here, you go for PubMed and then you will get tired just looking at all the references. Autocrine proliferating factor, unwisely used in HCG weight reduction sometimes. Here is more of it. Has been linked to the development of tumors, gestational, everybody knows that, trophoblastic disease, choriocarcinoma, hydatiform, osteosarcoma, bladder cancer, and prostate cancer. Imagine, this is basically a female hormone. Okay, now there is a pituitary variety of HCG. It's HCG-like that was discovered, and this is the reason that the pituitary gland is particularly in peri-postmenopausal women or somewhat elderly men, is sending enormous amounts of messengers, LH, FSH, to the gonads for them to work. And they don't get a response, and they make a mistake. This HCG is extremely similar to LH, FSH, and TSH, and this mistake will be expressed by having an HCG-like hormone, which is also characteristic of cancer. It also is a proliferating factor, but it has about 50% activity of tumor-generated or pregnancy HCG, but it's still no good. It's still a carcinogen. The remedy for this is hormone replacement, bioidentical, of course, hormone replacement. What this would accomplish is it would cause the pituitary to calm down. It's getting the feedback response from the hormone that's put in the system from exogenous sources, and will stop doing HCG. And this was well researched, and actually the fact was that this therapy did increase the pituitary production, which could be a lifesaver, because HCG eventually will cause cancer. Okay, then this guy said gastric colorectal cancer. There's all kinds of evidences for this. HCG-like hormone is a characteristic of malignant tumors that he talked about. Okay, this is a very interesting study that I have just done not too long ago. I think I presented this at the Las Vegas meeting. I don't remember what's the N here. There it is. 57 females, 46 to 87-year-old. We found that those who have no cancer, none soever, by this method, IMM method, 77% of peri-postmenopausal women had HCG in their blood. Those who have already had cancer diagnosis, every one of them had HCG in their blood. And these are women who really no longer would be pregnant. In the male population, it was quite lower. The IMM 14% with no cancer, 27% with cancer. Here again, because there is no diagnosis, it would be, I'm saying it, and dare to say, could be lifesaver that to use bioidentical hormone replacement, because this all HCG could be pituitary generated. Okay, here it says that if you do this treatment, the FSH should be at least 45, and that should cut down the HCG production. You may want to test before administering and post to see whether this was accomplished. If the HCG level doesn't go down and the FSH level is low, then there's going to be a tumor-generated HCG for certain. Okay, this is a study to show how many, this was published in Clinical Biochemistry 2010. I find that about 82% of all individuals who had HCG in their blood. There is an entity, it's called false positives. That's the investigators didn't understand that HCG, or did not suspect that HCG can be elevated years before there's a tumor. So that may not have been false positive. A test was done correctly. That hormone is there, and because it's there, it is tumorigenic. Okay, so I'm having the thing here. Okay, the cancer profile is not organ or site specific. Efficacy of the cancer profile. In lung cancer, we found 97% with diagnosed lung cancers, 92% with diagnosed breast cancer, 93% colon cancer, and overall 83 to 97% every single cancer patient, pathologically established cancer patient, had elevated tumor markers. This is just a patient who had a test. HCG actually was elevated here, and she started on a metabolic therapy. She gave up on it, and at this point she was diagnosed with breast cancer. Here, yet, that wasn't obvious to whatever method they were testing her. Okay, this is my brother with prostate cancer. You are good, and what you do is good, says Psalms. And here he is, as you can see it, his PSA has been normal all the way up to this point here. And at this point, like 10 years later exactly, just about, when his PHI remains elevated all the way through, at this point he's not diagnosed with metastatic prostate cancer, is receiving radiation and chemo, and he dies. At this point, he was diagnosed further with colon cancer, which, we know because his CA was quite elevated here. Okay, this is history where there is some ladies, there were no cancer here, and there's no elevation, there's no cancer, there's tumor markers elevated, there is cancer and tumor markers elevated. That's what these things are. So the profile is excellent for screening as well as for follow-up of a clinical how-abouts of an individual. Here is another situation like that on lung cancer. There's 8 months history here. You can, follow this here. I hope that's on your computers. Here's the longevity profile, which is a part of it is the cancer profile, and it has all the other constituents. This seems to be an extremely productive, kind of revealing kind of a profile. Here is an individual. This is a medical doctor, 58-year-old American woman in Florida, Western Florida. You can see that she has an elevated HCG, elevated PHI, the normal, so PHI being 34 or less. Her C-reactive protein is about 3 times what it should be. Her homocysteine is high, it should be less than 7. Her lipoprotein, LDL, that is, the bad cholesterol was very high, in the high danger zone. Her DHEA was 30, which is that of a 90-year-old woman. We see this all the time. A 30-year-old person may have a DHEA level of a 120-year-old. Her estradiol was, and progesterone, testosterone, none was detected. Her insulin-like growth hormone was that of a 100-year-old. Her parathyroid hormone was quite elevated, indicating bone loss, osteoporosis. Her thyroid-stimulating hormone was very high, so it's very hypothyroid. So there's a lot of things that she needs to be done. So what she needs to be done is, what happens here is that she may be already just developing cancer. She may have a myocardial infarction or a stroke any moment. Her immune system is impaired. Her libido is non-existent. She's hypothyroid. She's developing osteoporosis. Her youth is wilting away. People are whistling at me because they like what I'm talking about. And this is what she should do. Consult with a metabolic physician for cardiac cancer workup. Detoxify body, mind, and soul. Avoid harmful foods, drinks, air, thoughts, changing the gene behavior, genetical behavior. Take plenty supplements, including wise use of hormone replacement therapy. Exercise, strength, stretch, speed. Rest and sleep well. Spend time outdoors for light and air. Meditate and pray. That's what you can do. There is no need here for any serious biomedical involvement or a CT scan or anything like that. First, these clinical biochemical markers need to be corrected, and there may be a follow-up if these remedies, which are named here, not working. Okay, there's one more thing, then I guess I better go home. This longevity profile, 24-year-old male soft tissue sarcoma. You can look at that. He has a lot of HCG in his urine. He definitely is not pregnant. He has a lot of pH phosphoxyls isomerase. This is the autocrine proliferating factor, autocrine motility factor. And his liver enzyme is elevated for whatever reason. His DH is that of a 70-year-old. He's 24 years old, so his T cell production is low. Thyroid stimulating hormone is up in a questionable range, but it's normal. His testosterone is very low for a 24-year-old. His parathyroid hormone is fine. C-reactive protein is sky high. This means, of course, he has a serious inflammatory situation going there. And his homocysteine is that it gives him a 31% increase for coronary risk. Lipoprotein small a is elevated. That's a coronary risk factor. LDL direct is also elevated, should be less than 130. He also has elevated sugar, all kinds of problems. So a metabolic physician could really do a lot with this. So metabolic non-toxic therapy working with epigenetics would be the answer. And of course, there is so much more. I hope this is all on your slide, and I'm sure I'm way over time. So, thank you. Bye. If you have any questions,
Go ahead. I think you do have one question here, Doctor, in the back. Go ahead.
You have to call me because I never, let's see, ursolic acid, I think it's called ursolic acid, what the thing is. And you need to call in, and we can, I think that's what it's called, ursolic acid. And that's in some herb that I cannot name at the moment. Call me and I will let you know. The PHI enzyme, I don't know the prices, but it's somewhere around $100. The total profile is somewhere around between $350 to $400 for 8 tests. The longevity profile is from $800 to $1,000 with the 60